Good afternoon, everyone. We will get started here in just a few moments. If you are a committee member, if you would put your name in the chat, that way we can make sure we count everybody for a quorum and get out on the meeting minutes. If you are a committee member who's on the phone, if you would unmute and let us know that you are here, we would appreciate it. We'll get started here in just a few moments. Thank you. Again, good afternoon, everyone who just joined us. If you are a committee member, if you would put your name in the chat to let us know you are here. If you are a committee member who's on the phone, if you would unmute to let us know that you are here, we would appreciate it. Michael, I'm going to do another count, but last time we were just one or two shy. So I'll let you know when we have a quorum.
Okay, very good. While we're waiting, I'll just ask for the committee members to make sure you've had a chance to review the meeting minutes that came out yesterday for our meeting back in October, and just see if you have any comments on that.
Well, Michael, by my count, we are just shy. There's lots of attendees today, but we are just like one shy of a quorum. It must be the holiday season and everyone else.
Okay, well, that's
I don't know
fine.
if you want to wait till next month and we'll do the.
Well, we'll just see if someone joins us a few minutes later, but
Okay.
maybe let's just talk briefly if anybody has any changes or recommendations for the committee minutes from our October meeting. I think one thing that I noticed as I'm looking at the meeting minutes is that was the first time we tried to have an anchor location. So there were several of us who were in person. And I don't know if we need to reflect that in the meeting minutes. First, I mean, we did end up having to participate by phone from the anchor location, and that wasn't that successful. So many of you may be participating remotely, may not feel like you even feel like you're in a position to comment on the accuracy or completeness of the meeting minutes, having missed some of the content. But that was my only thought, to see if we wanted to reflect that we had made an attempt at an anchor location and who had actually been there. But are there other comments from members of the MAC about the committee minutes as proposed? No. Okay, well, when we get a quorum, then we'll look to take action on those. Thanks for displaying those for us, Sharon. Okay, we have, I believe, our final appearance by Dale Omby today as a member of the MAC, and he's moving into retirement. So we did want to just thank him for his service on the MAC and participating in these discussions over the years, and see if he had any final parting words for us before we wish him well and moving into that next stage of his life.
Well, I appreciate that, Michael. Yeah, it's been 31 and a half years, and it's a little scary, but I've just decided to take the plunge. So I have also appreciated the opportunity to engage in dialogue with both the MAC and, of course, DHHS. I think for the most part, our discussions have been productive. I also want to thank Maris for attending. I haven't attended the past several years, but Maris has been attending as my designee. So I believe that Maris would like to say something.
He's surprising us all with a spontaneous retirement as well. No, we can't have
that. I am not that fortunate, Michael.
Okay,
thank you for thinking of me. I just wanted to announce also a small change here. As I'm taking over for Dale, I'm actually going to be assigning another designee that's going to be a permanent fixture in the MAC. Melissa Presley, who's here on this meeting, will be the designee for DWS and will be a permanent fixture of this committee moving forward. I will join when there is a need, but I think you'll start seeing Melissa than you have seen me in the past.
Okay, thank you. That's very helpful. And Melissa, we welcome you and look forward to working with you going forward. Okay. All right. Well, thank you. We appreciate, again, your service, Dale, and engagement with the MAC and on Medicaid issues. And we wish you well in that next stage of life. Hope that all goes well for you.
Thank you so much. And since I have many, many other things to do before my last day, I am going to jump off. But I appreciate the recognition and wish you all very happy holidays.
Okay. Thanks, Dale. Okay, next on our agenda, we have the governor's budget proposal, and Eric Grant from the department is going to walk through that for us. Eric?
Michael, we actually have a last-minute change of plans, and I'll cover some of the governor's budget items in the director's report later.
Okay. Very good. Love change of plans. Was aware of one change of plan, not aware of this change of plan. So appreciate that. Let's go to item number 3 then. Greg Trollin, the HEDIS CAPS measures. You want to go ahead with your presentation?
You bet. Thanks, Michael. Yep. Good afternoon, everybody. I'm Greg Trollin. I'm the office director for the Office of Managed Healthcare. Accompanying me is Jennifer Meyer-Smart, who's our assistant office director for the Office of Managed Healthcare. And we're going to tag team on this presentation. I'm going to start out talking about some general areas of quality that we're engaged in, and then Jennifer is going to get into some of the specifics on some of the measures. So All right. Again, welcome everybody. We usually give this presentation on an annual basis, typically at the end of the year. And that timing is partly due to the fact that we get our information for our HEDIS and CAPS measures, typically in the fall. And then shortly after that, we get the national average information, and then we compile that into the report that you guys have in front of you or was distributed to you by Sharon. Next slide. And you can skip down to the next slide as well. Thanks, Jen. Anyway, so a quick overview on areas in managed care. We want to just share some of the activities that we're engaged in, and specifically our CO quality incentive pool, our hospital quality project, some quality solicitations that are currently in the works, our ACO collective performance improvement project, and then just a quick note about integrated healthcare. So this particular fiscal year, the division was able to engage in and set up a quality incentive pool for the accountable care organizations. And this was specifically to engage in and allow the ACOs to earn dollars based on performance on some key areas and some key measures that we had identified with the ACOs for inclusion in their contracts in this particular fiscal year. Again, we wanted to focus on initiatives related to increased consumer engagement, emphasis on preventative care, and then again, general focus on quality. Again, the ACOs are able to earn dollars through this quality incentive pool based on performance on specific benchmarks, as well as performance improvement on specific measures. And these measures include consumer engagement, in particular, the development and or increased support for member engagement panels, member contact, and reducing barriers to access. Again, focus on specific HEDIS measures, particularly well child visits and immunizations for child, health plan accreditation, and then data timeliness and accuracy. Another thing that we're engaged in is a couple of solicitations. We currently have 2 RFPs that are open and out for bid right now. One of them is for a managed care quality contractor. We intend to hire a vendor that can come in, help us both do short and long-term strategic planning on quality, but also look at reimbursement, innovation, and different methodologies associated with value-based payments. Like I said, this RFP is open for bids and it closes on January 19th. Our second solicitation that's currently in the works is our population health management system. And this is specifically to bring on a vendor that would be responsible for the reporting that the department is required to do for CMS related to the core set measures. And so that solicitation is open now and closes the day after Christmas, which is the 26th. Next item is our hospital quality project. This last legislative session, Senate Bill 126, was specifically around changes to the methodology related to directed payments. And specifically included in that legislation was the requirement that there be specific hospital quality measures. And also within the context of that, to include penalties to hospitals for not meeting those specific measures. Just so you know, state-directed payments are intended to support increased quality and access to Medicaid services for Medicaid members. And right now we're in the process of finalizing the particular quality measures that will be employed as part of this program. And then we anticipate that in FY25, the quality reporting will start, as well as the evaluation of performance. All right, next item is just our ACO collective performance improvement project. As part of CMS regulations, managed care entities are required to engage in clinical and non-clinical performance improvement projects. Typically, these projects have been managed and conducted on individual plan basis. However, what we did starting the tail end of mid 2022, we had proposed that we engage in a collective performance improvement project that all the ACOs would participate in. And that specific performance improvement project was around well-child visits for the first 30 months of life, which is an important element for preventative health as well as well care for kids. And so we had set it up so that we have, some reporting period years within the context of this. And the first activity associated with it was this creation of a well-child visit card, which was developed and then is also, if you'll see, it's available on our website to download, but we distributed this to the plans. We also made it available to the public for use. The plans then, based on strategic distribution, looked at where to disseminate these both to members directly, but also to their provider networks. And so anyway, it's an effort to really focus everyone's attention on well-child visits, which we know is a critical part. And if once we get to actually looking at those measures, Utah has been behind the curve to some degree when it comes to our performance with respect to the national average. All right. Next item is just about integrated healthcare. We wanted to just highlight that integrated healthcare has a variety of benefits. Again, integrated healthcare runs on a continuum, from just having the same payer responsible for different programs all the way to having integrated clinics that provide the whole spectrum of care, both physical, behavioral, and in some cases, even dental care. But for integrated healthcare, it improves health outcomes for individuals with physical and behavioral health conditions, reduces fragmentation and lack of coordination. It reduces healthcare utilization while reducing healthcare costs, improves treatment adherence and reduction in stigma for those seeking behavioral health care, and then improves the patient experience through enhanced care coordination. In Utah, historically, and particularly in Medicaid, our physical and behavioral health services were separated through our accountable care organizations, and then the behavioral health services being delivered by our prepaid mental health plans. In January of 2020, Utah established the Utah Medicaid Integrated Care Plans that combine physical and behavioral health services. Those plans currently operate for adult expansion members and are specifically available in Davis, Salt Lake, Utah, Washington, and Weber County. The department and the division, as our name, as our new our new consolidated department name, the Division of Integrated Healthcare states, we're committed to continuing to explore ways to expand the availability of integrated care. We're looking forward to updating our quality care, our managed care quality strategy, which is due to CMS like the fall of next year. Although our intent there is to really, as we talk about quality and as I've talked about just these various activities that we're engaged in, making sure that what we do is aligned and makes sense. We also look to expand and evaluate measure performance to go beyond just our historical contract requirement that the plans measures be at or above the national average. And then finally, we intend to explore and implement ways to incentivize performance and outcomes through value-based reimbursement models. And now I'm going to
before you move on.
Go ahead, Mike. Yep.
So this presentation didn't seem to appear in the meeting materials that was sent out before the meeting. So I'd just like to request that any presentations like this that we don't currently have distributed could be sent out at the end of the meeting.
Oh, certainly.
We can do that.
Yep. Yeah, thanks. Okay, I'm going to tag team now with Jen.
Okay. All right. Next, we're going to talk about the quality measures and why they are important. And we'll also look at a sample of the quality measures. And you can find the additional quality measures in the quality report that Sharon emailed out to the group. So if you have any additional questions on those. First, we have HEDIS, and that is Healthcare Effectiveness Data and Information Set. It's widely used by more than 90% of health plans, and more than 190 million people are enrolled in health plans that report quality results using HEDIS. HEDIS information is used to improve care and services provided to enrollees, and the data collection and analysis is led by the Office of Healthcare Statistics within the Department of Health and Human Services. In addition, HEDIS allows for a comparison between health plans, and we'll look at a few of these measures and comparisons in the following slides. The next one is CAHPS, Consumer Assessment of Healthcare Providers and Systems. This is performed by a third party to measure perceptions of care. It asks enrollees about experiences with their health plan and the services they receive. The health plan uses the survey results to identify strengths and weaknesses in their service delivery. It also provides consumers with information to help them select a health plan that is right for them. And Utah health plans are required to submit HEDIS data and CAHPS survey results to promote informed consumer choice in plan selection and, again, measure quality of care. The next slide, I'll just mention a few points about quality measure tracking. The reporting year 2023 is actually for calendar year 2022 data, as you'll see in the next slides. And as I mentioned, the data collection and analysis of Utah HEDIS and CAHPS is a collaborative effort led by the Office of Healthcare Statistics. And that HEDIS and CAHPS data can be viewed on this website that we have here on the slideshow, which we'll share after. That's also in the report. HEDIS and CAHPS quality measures are tracked by the Office of Managed Healthcare for adult Medicaid, child Medicaid, CHIP, UMIC plans, and PMHPs. Okay, next we'll look at a sample of the HEDIS and CAHPS measures reporting by the ACOs. So on this slide, we have the W30 well-child visits in the first 15 months. And you'll see on these slides that the national average is indicated by the horizontal line up here at the top. You can see how each plan compares to the national average on this measure for the reporting years of 2021 through 2023. And on this slide, you will notice the state average is consistently below the national average. And as Greg mentioned earlier, the collaborative ACO PIP chose this measure as their topic, and in 2023 produced the well child visit tracking card. The next slide is the well child visits 15 through 30 months. And again, here you'll notice that the state average is below the national average as well. These two measures indicate the percentage of members who had well child visits with the primary care provider during the last 15 months. And the W30 measure actually replaced the W15 and W34 measures beginning with the 2021 reporting year. The next slide is CIS Childhood Immunization Combo 3. And you'll notice here that the state average is decreasing slowly. One thing we would like to do with immunizations specifically is work with the health plans to identify any challenges or obstacles that they encounter with these. The next slide is IMA, Immunizations for Adolescents, Combo 2. And again, you'll notice here that the state average is decreasing slowly and again is below the national average. Okay, so the next slide, this is actually an example of one of the CAHPS measures, UMIC Access Customer Service. And CAHPS surveys are conducted by mail, telephone, and online. And this year they were conducted in March through June of 2023. The response rates varied between 15 to 20%. Attempts were made to survey 2,000 member households for the adult survey and 3,000 for the child survey. The survey drew members who were continuously enrolled in the plan for the last 6 months of December, as of December 31st, 2022, with no more than one enrollment gap of 45 days or less. And I will note that to combat low response rates, the sample sizes were increased in 2023. And just to mention as well, the response rates are a concern and a challenge nationwide, not just in Utah. Surveys were considered complete based on the following criteria. The respondents answered at least 3 of 5 key items, and responses indicate that the respondent meets the eligible population criteria. 4 rating questions assess overall consumer satisfaction with their healthcare, personal doctor, specialist talked to most often, and their health plan. And the response options for overall rating questions ranged from 0, which is worst, to 10, which is best. A composite score is calculated for each of 4 domains of member experience: getting the needed care, getting care quickly, how well doctors communicate, and their customer service experience. So that is our CAPS measure example. And that is the end of our quality presentation. If anyone has any questions.
I have a question. So we've talked about the ACOs and the UMIC contracts. You had mentioned earlier in one of your 2 presentations, Jen and Greg, that you gather the information on the PMHPs as well. So I'm just also curious if you're planning to present and report on that information. And then second question, how do these numbers compare to the fee-for-service performance of the experience of those enrolled in the program?
Yeah, thanks for the question, Michael. We don't have anything prepared that does a comparison on the PMHPs for this meeting, but we are certainly open to mapping the performance on the specific PMHP measure, and even within the context of doing some comparisons between the PMHPs and the UMIC plans, because we did intentionally include measures that were the same, so that at some point we'd be in a position to do that type of comparative analysis. So we are open to doing that. I think another thing that's also important, again, historically, we've really just done a presentation related to the ACO measures. I think what we intend to do in future presentations will really to kind of expand that to say, what's the performance across the board for our managed care entities with respect to the quality measures that are included in their contracts, so that there's visibility for all the different programs that we run. So behavioral health, dental. Yep.
Yeah, I think it's interesting that we're talking about at the beginning of your performance or your presentation, integrated healthcare. And then we're just focusing on the physical health. There's the integrated contracts on UMIC where we're starting to look at performance, but I think it would be helpful to look at the prepaid mental health plans as well and make sure we're approaching the whole range of the care. And
Yep.
To the point you just mentioned, even the dental type of benefits where we are able to capture that information. So we are not just focusing in one area exclusively.
Yep, that's a great suggestion, and we intend to do that. And to your the second point of your question about fee for service, Brian, I don't know if you have anything to add on sort of the comparisons between what we see on measures with respect to managed care versus fee for service.
I do not, but it is one of our objectives with the RFP that we're undertaking right now in order to build our capability to make those comparisons and subpopulation analyses. So, but we don't have that prepared right now.
Okay. All right. Looks like Stephanie has a question. Stephanie, go ahead.
Yeah, I was just curious if there's a reason why you all are going to be looking to outsource versus building that capacity internally for the expertise that you talked about, Greg.
Yeah, I think initially we wanted to bring the expertise in so that it becomes not that we would just sort of offload the responsibility, but within the context of having a vendor with substantial experience in the quality arena, that becomes then an educational opportunity for us. It allows us to more quickly, get up to speed understand the quality landscape, educate our staff. Again, I don't see that after probably the first the first contract that we have with this vendor. Again, we're trying to build internal capacity, but our goal is to increase our abilities as quickly as possible. And so having a vendor come in and do that is going to be particularly helpful for us.
That makes sense. Thank you. And how is all of this impacting like how is kind of like how the plans are doing with quality metrics as it is right now? How is that going to influence like decisions made in the future around putting more responsibility on the plans, particularly like the CalAIM project, the HRSN projects, you know, I mean,
Right.
I mean, I've been following and I've talked to a lot of people in California. I mean, I think that is maybe a concern of like, if we're going to be like, how that's going to kind of, I don't know. I think you get what I'm saying, Greg.
No, I get what you're saying. I would say that we don't have all of that fleshed out, but they're important questions. I was talking with staff the other day and just talking about the transition of Medicaid from just being strictly a payer of claims to now really getting into how do we impact the social aspect of healthcare, and as we start to do that, what are the expectations that we're going to have of our particular contractors to be able to take on the responsibilities that tie out to some of these things, like you mentioned, housing supports, increased care and case management, particularly with pre-release incarceral individuals and things like that. So we're still working that out. Again, we also see that our quality vendor is going to help us construct the infrastructure within our contracting that increases that level of accountability and pushes us in the direction of ensuring that what we want to see happen is performance based by the ACOs and any of the other managed care entities that are also, serving these individuals.
Thank you. Can I ask one more question? And sorry, I might have missed part of this because I was a little bit late. But I know that y'all have put consumer engagement, into the contracts, and I'm just curious, like, I'm sorry if you went over this already, but I just want to understand, like, and maybe the plans are going to go over this too, but like, are there specific requirements or like how flexible, like what counts? Because I think that there's a lot of, I don't know, there's always a shared language about what is consumer and community engagement. So I'm just curious how you all are going to be policing that.
Yeah, we started out, I think, with the intent that they would be reporting, structure these consumer engagement panels with, some just specific guidance around who would be represented, how many individuals would be on these consumer engagement panels, what types of reporting the plans would do to us with respect to the conversations and the feedback that comes out of those particular panels. And then subsequent to that, what the ACOs are doing with the information and how they're using that information to inform their operational processes. So again, these are things that we intend to sort of initially say, we want you to start doing this, report back to us what you're doing, how you're doing it, what the results are, and what you're doing as a result of the information that you're getting. And then sort of, tying out additional requirements as we, particularly in this fiscal year, get more feedback about how those consumer engagement panels are going. I think one thing to note is we also are intending and working on developing a similar process just for the fee-for-service side. So that's an important element of us just bringing the consumer voice into our more intentional about having that level of information and feedback informing what it is we do and how we do it.
Thank you.
Certainly.
Okay.
Okay, thanks, Stephanie. Do we have any more questions on the presentation before we move on to the ACO response? Okay. All right, then let's go ahead and go with the ACO representatives. I think maybe we can start with Select Health, then Health EU, Molina, and Health Choice in that order, if everyone's here and ready to go ahead. So Select Health, please.
Thank you, Michael. This is Todd with Select Health. I have Adam Osborne here, who's one of our managers in our quality department to go over some of our HEDIS and CAPS measures and what we're doing.
Thank you. I'm trying to get it to share. Not as familiar with Google Meet, so hopefully my screen is sharing.
Not yet, but oh, there we go.
Okay. Okay. So I have a couple monitors, so I apologize if it looks like maybe I'm not looking at the group. It's just trying to monitor what's going on. So this is just meant to be a very high level overview. Like Todd just mentioned, our quality team, what's going on, but once again, extremely high level. So, but excited to be with this group today. So what I wanted to do for this discussion was talk about what were the things that I felt like were successful on the quality side through 2023, and then what are the focuses we're going to do going forward. So the very first thing I want to focus is our mission and vision. At Select Health, that really is a critical aspect when it comes to our decision making. As internally, our employees refer to them as caregivers. This is what we live and breathe. We want to make sure that when we make a decision, is it within our mission and our vision? So our mission is helping people live the healthiest lives possible. And our vision is to be a model health plan by providing high health benefits and superior service at an affordable cost. And once again, I just cannot emphasize this enough. At the end of the day, this is what it comes back to. This is where you have passionate caregivers, passionate employees at Select Health that live and breathe this mission. So some of the highlights that I want to talk about through 2023 is year-round focus of oversight of measures. So we were able to do some new strategies with our subject matter experts on the different measures. Refer to them, sometimes I might say SMEs, that's what I mean there. So these measure owners, these SMEs, what they're able to do is throughout the year, they have better reporting to be able to monitor the measures and the performance and see if there's a measure that's starting to dip, what can they do proactively to see if we can kind of change that measure? What barriers are they facing to proactively get that done? At the end of the year too, in addition to that, those same measure owners, what they'll do is they provide a kind of like a SWOT analysis. What went well? What do they need to improve on? And what are they going to be doing different through the following year? So actually, as we speak, through our measure analysts, they're finalizing this right now for 2024. We have what's called a quality improvement committee. In this committee, it has Select Health representatives, it has committee with physicians. What we do in this committee is we really talk about what is it that the health plan is seeing, what is it that our physicians are seeing, and how can we collaborate better to help improve the quality of care? What is it that the clinic is seeing, and how can we be a better partner to help get members in and get the gaps of care closed? Probably just like everyone else, we understand the importance of member engagement. We need to get members engaged. And so some of the avenues that we do this through is newsletters, direct mail, live calls. We also have a program called the Quality Performance Program. And what we do is we work with our member within Select Health, we're able to work with clinic managers and see, once again, from the clinic side, what is it that they're experiencing, what's going on? And once again, can we provide materials? What could we be doing different to really get members engaged and get them in? We also have cross-expert department and collaboration. And what I mean by that is we have a subject matter expert for one measure and usually a different subject matter expert for a different measure. So in 2023, we really wanted to make sure we don't want to get member abrasion. Jennifer talked briefly about CAPS. I think part of the issue we're seeing is just member fatigue, member abrasion with different materials being sent out to them. So we have maybe our well child measure as well as our expert for immunizations collaborate together and say, what can we be doing instead of doing different initiatives? How can we work together to help spread awareness and help reduce member abrasion. For 2024, we have a lot going on. So once again, just extremely high level CAPS. That's a big one. As previously mentioned, we're seeing a decline in member response rates, and we want those member response. We want to see what's going well. What can we do different as a health plan? So internally at Select Health, we actually created a strategy committee that's going live and to focus on CAPS. What is it that we're doing, but what can we be doing different to help improve member engagement and increase those member responses? As previously mentioned, we have our policy improvement projects. So we have the WCV, W30. These are those well-child visits. I threw in immunizations in here because even though it's not part of the PIP, we understand how critical this is to get members in and get them immunized. Part of our discussion that we've had with clinics is many members now, especially post-COVID era, are more hesitant to get those immunizations. So working with those clinics, getting feedback, how can we partner better to get members excited to get their immunizations done? And then this is the FUH measure, which stands for follow-up after hospitalization for mental health visit. So we have a great collaboration there for 2024. We continue that, I should say, to improve our measures there. The last thing I want to talk about is just enhanced member engagement. And what I mean by that is we have more data than we've ever had before. And so how can we strategize the data that we're receiving? How can we use data analytics to just not look at our population, but really get down to zip code or street level and say, okay, in this zip code, we're struggling with breast cancer screening. Why is it that we're struggling with it? Is it just not enough mammography? Do we need to get a mobile mammography there? If it's immunization in a specific area, we could really target down our strategy to that population, this subset of area, and really focus on that area and help improve the care there. So that's Select Health at a very high level. I just want to say thank you for letting us be here. Once again, I just go back to our mission and vision. We are very passionate about the community that we serve, and we're so grateful to be a part and serve the community that we're in. So.
Okay, thanks, Adam. I'm going to hold on the presentation questions until we have all four of the presentations go, and then we'll go back through the questions. So let's go to Healthy You next, please.
Hi, this is Dana Patterson. I'm the manager of the quality team here at University of Utah Health Plans. Can you all hear me?
Yes, we can.
Okay, great. Let me switch over. I've got a few slides to share with you all. Okay, can you see my screen?
Yes, we can. Thank you.
Okay, great. Yeah, thanks for the opportunity to present kind of the activities that we're working on to improve our HEDIS measures and the health of our members. And again, kind of like what Adam said, this is really just a high-level overview of some of the initiatives that we've been working on and have planned for the future. So it's certainly not a comprehensive list of everything going on. So I wanted to highlight the well-child visits, as I think Greg mentioned about the well-child visit record card. So we've been working on promoting that to members, children under 3 years old. We're also developing a newborn resource packet that will go out to all newborns. It will include that card, but also some additional information, education on developmental milestones, what parents can expect at well-child visits, immunizations, car seats, and so forth, really to just get those kids off to a good start, getting healthcare right from their start of their lives. We've been doing this summer and fall, doing heavy member outreach via phone calls and letters for all age groups, 0 to 21 years of age. We've also added this measure. We've added value-based payment arrangements with our providers to help improve our HEDIS score. So basically, we're paying providers who are participating with us to close care gaps and get these kids in for well visits. Going forward in mid 2024, we're looking at launching a Text for Baby, Text for Kids program. That's a program that our vendor has developed and used successfully in others Medicaid in other states' Medicaid programs. So we're looking forward to that. And it's basically a texting educational campaign. It starts as soon as someone becomes pregnant, they can join. all the way up to age 18, and just getting some reminders, education about different things that are important based on either gestational age or birth age. A couple of the last bullet points under well child visits there are some data issues that we're working on to improve our data capture for this measure. I won't go into too many details, but just a few things that are kind of depressing our rates where we're missing well child visits in our rate calculation. So we're working to improve that. And then going along kind of the same lines with child and adolescent immunizations, really tied into those well child visits. So we're really promoting, trying to push those kids to get those well child visits because those physicians are the trusted voice for immunizations. We've also added this measure to the value-based payment arrangement program. And we just recently wrapped up a pilot texting program specifically focused on the HPV vaccine that we're doing in partnership with Huntsman Cancer Institute. So we're excited to see the results for that campaign. Looking at some of the adult measures, for breast cancer screening this past summer, we implemented an interactive voice response education reminder call for members. And what was, I think, unique about this was that we were able to partner with a couple of our partner mammography screening centers and offer a warm transfer to that scheduling center. So if the person was on the phone, they took the call, they could be transferred directly to the mammography screening center to schedule an appointment. This is also one of our value-based payment arrangements, and we're doing additional member and provider reminder initiatives for this measure. Cervical cancer screening, we also did an IVR campaign. This one offered a warm transfer to our health plan customer service to help people find a primary care provider or a women's health provider if they didn't have one, and then get that appointment scheduled. We talk a lot about well child visits for kids with Medicaid, but we really feel that for adults, those are critical as well, just having that regular source of care, primary care, preventive care. So we've been heavily focusing on that with doing member outreach phone calls and letters, providing resources on how to find a primary care provider. And we're expanding that with an IVR campaign as well so that we can reach additional members. We've also been pulling in our pharmacy and care management teams to help with improving our HEDIS performance. Our pharmacy team, they've implemented a medication management therapy program where we have health plan pharmacists contacting members to support their adherence to cardiovascular and diabetic medications. And while that pharmacist has the member on the phone, they can also help that member address any other identified care gaps around diabetic eye exams, blood pressure, and so forth. And again, in order to expand our scope, we are looking at, we're actually working on it actively now to implement a IVR refill reminder campaign for those diabetic and cardiovascular medications, as well as asthma controllers and antidepressant medications. For care management team, they're really becoming heavily involved with our HEDIS process and reducing care gaps. We have established disease and care management programs targeted for targeted conditions to support HEDIS measures. They're doing follow-up after members discharged from the hospital to ensure appropriate follow-up visits and making sure that that member has a source of care after they're discharged. We also have an access assistance team to help connect members to healthcare providers and appointments. So really trying to get them into the care that they need. And we did want to touch on, we didn't go into a lot of the detail of the individual rates in any of the presentations so far today, but we did want to just talk about some of the things that we're seeing in our HEDIS rates related to the public health emergency and Medicaid unwinding. We're really seeing some wide swings in our denominator sizes, and it's really going to impact, looking at trends over time when our population is changing so drastically. So looking just between measurement year 22 and 23, we're seeing most measures are going to have more than a 20% decrease in denominator size due to Medicaid unwinding. several measures are going to have 30 to 40% decrease in denominator size. I put an example there. The HEDIS, the well child visit measure. For measurement year 22, we had over 31,000 members in the eligible population for that measure. So far in measurement 2023, we're down to 20,000 members. That's as of October 23. So we anticipate that that number is going to be smaller once we have full year data. So there's really been some challenges with reporting the HEDIS measures kind of in this climate where we're seeing these broad swings in enrollment. And that's all that I had.
Okay, thank you, Dana. All right, next, let's have our presentation from Molina Healthcare.
Hi, I'm Lynette Hansen. I'm the AVP of Quality for Molina. I did not get the memo saying there was to be a presentation. I came prepared to discuss what we're doing, so we'll just go from there. I can echo some of the things that Dana has expressed with regard to the PHE unwinding. We have seen great volatility in the denominator in our measures as a result of that, to the point of seeing a 7,000 member loss in one HEDIS measure from a month-to-month basis. So that is, going to impact the rates dramatically. In some cases, we see that we have a larger number of denominator members who were numerator compliant being lost than those who are not numerator compliant, which is going to impact our overall rates at the end of the year. Nevertheless, we've done a deep dive on the measures, focusing on the childhood measures, the well child visits in the first 15 to 30, well, 0 to 30 months. Some of the challenges that we've been able to identify, one is that there is a lot of ambiguity or misunderstanding on the part of members as to their eligibility. And I think the PHE helped lend to some of that confusion, and the unwinding certainly complicated that. As we see new moms who recognize that they have coverage for themselves, don't understand all of the dynamics of what they need to do to get their baby enrolled, and then assume that when they lose their coverage, their child has also lost coverage. So we've done quite a bit in regard to education to help these moms understand what the rules of the game are, and that they do have coverage to assure that they get that done. We have a very robust new moms program. We start out as soon as we learn about the pregnancy. We use a platform for omni-channel communication that is secured and protects PHI, so they have to have a password to enter into it. They basically get an SMS text message that is like ringing the doorbell. It says, hey, you've got an important message for Molina. When they click on the link, it takes them into a secure site where their information is housed, and it speaks specifically to what they need to know, provides them links that takes them to areas where they can receive education, to an online provider directory to schedule an appointment. Also provides information on various member incentive programs that we have and other tools that we have to help them along the way with their healthcare journey. We've had really good active participation in this omni-channel communication platform, and find that members really enjoy using it. And so it's been really great for us to be able to provide education and links to members to give them the information that they need. We do things such as a new member welcome message that actually gives them a new piece of information about every 2 or 3 days, gets them to the provider portal where they can see how they can access their insurance information, what their benefits are, links them to finding a provider, takes them to areas of health interest that may be specific to their condition or their needs, and engages them for a period of time. We have birthday reminders that go out saying happy birthday. It's time for you to get an annual checkup. You may also be due for cervical cancer screening or breast cancer screening. All of these are tailored specific to their age and category. In addition, we have member incentive programs where we incentivize for completing services. These are linked very closely to our provider incentive program. We provide missing services lists to our providers and work with them very closely in obtaining access to supplemental data to support the information that we receive. In 2023, in the last quarter, we identified some measures that we needed some additional help on. We went out to some targeted provider offices and offered them a provider luncheon if they would do outreach to the members on the missing service list, get them scheduled before the end of the year. And as a reward, we sponsored a lunch for the office staff that were involved in getting those appointments scheduled and completed. We had very good response on that. Data has been a particular issue for us. We don't have internal access to a lot of providers, so we work very hard to get direct EMR access. We've been working on supplemental data submissions with many providers. And as we've done a deep dive, we noticed that we had a decline in our immunization rates, both childhood and adolescent. It took us about 18 months working very closely with USIS because we believed that there was some sort of a gap that was preventing us from getting all of the information we needed. We finally got that cleared up in September of this year, and as a result, with the latest data refresh, we had a 30 percentage point increase in our childhood immunizations, which puts us back on par with our market competitors. It makes us feel much better about the work that we've been doing. That's a lot of information, and that's a lot of what we're doing, and I'm happy when we get to the question portion to entertain any other questions about what Molina's doing. I'll just add one more thing. We also have a multidisciplinary team that meets on a regular basis, and we do an analysis of our CAPS survey, identify where we have opportunities for improvement, do a lot of root cause analysis and deep dives. Have implemented some great programs. One in particular is our Care for Care program, where we identify members who've had multiple calls to the customer service center or had complaints or grievances. We do a follow-up outreach to those members, make sure that all of their issues have been resolved, educate them where possible, and then send them a gift as a thank you for sharing their information and time with us.
Okay, thank you, Lynette. Okay, let's have a presentation now from Health Choice.
Hi, my name is Rachel Vasquez, and I am the Quality Program Manager for Health Choice. I'm also new to sharing on Google here, so let me see if I can get this up. All right. So first of all, I wanted to echo one thing that Lynette had brought up as far as data goes. It is a difficulty that we also experience not having some of the access to an internal hospital system or things like that. So definitely EMR access is something we work on trying to obtain access to more of our providers' EMR. And we definitely see some changes once we can kind of pull in records from those EMR. So along with the data EMR aspect, working with immunizations and USIS, a lot of other considerations that we have when it comes to data is the mapping as well. And we found that one single, code mapping change also gave us an increase of about 28%, just because of a code not being accepted by our vendor correctly. So those are always things that we're looking at monthly as we do our refreshes, is trying to analyze if there's any other data issues that could be preventing us from capturing the full gamut of data that we need to, that can be reflected in these rates. So things like provider specialties, if those are not reflected appropriately, you're going to be losing captures on things, especially for the measures related to children. There are HEDIS measures that have to be performed by specific provider types. And if a provider is working as a pediatrician, but also on the side working as a hospitalist, and that's how the claim is coming across, those visits may not be captured appropriately. So there are adjustments that we have to make in that. So just to get started, I'll just give a brief overview. So we, our quality team at Health Choice has a monthly measure focus program. We follow the PDSA methodology when we evaluate monthly, the planning and studying of what measures we're going to be tackling in what months. We do this with provider engagement in our monthly meetings with provider offices, and when we're reviewing gap reports with those provider offices, but also in consideration of the provider newsletter and the member newsletter, and what kind of educational pieces we want to try to get out there, or what additional robust initiatives we need to put in place in order to improve upon our quality. So this is kind of something that really guides us throughout the year. So I wanted to speak about some of the more specifics as far as initiatives that we are working toward for the various measures. And so for the child and adolescent HEDIS measures, a lot of the work that we do is similar among the different measures. So we do telephonic member outreach. We have provider office care gap reports that we review with the provider offices. We encourage them to outreach our members, but we also perform that member outreach as well to try to give reminders when a child is needing to come in for their appointment. And we have also this year implemented a member incentive program for the immunizations for adolescents. Those ones, we feel what we see the most is, either the HPV vaccination is missing entirely, or maybe the second in the series is missing. So for W30, we did go ahead and send out the well child visit record card to all within that denominator for both the 0 to 15 and 15 to 30 months. And that was mailed out in August. And then we also communicated with providers on where they can access those cards or print them for members in their office as well. We have a magnet for your fridge that we are going to be working on in the coming year to send out to members in this demographic, so that they can have a reminder just right up front as far as what the schedule is and when they need to be taking the kiddos in for their appointments. We've also done a reminder postcard for all in the eligible population for well care visits, ages 3 to 21. They should have an annual well care visit. And that was something that we split out between, of course, the ages of 3 and 17 and 18 and 21. And then we'll go into, for cancer screenings, we do have IVR campaigns that we run. We did a breast cancer screening as well as a cervical cancer screening this year. The breast cancer screening included a warm transfer for them to be able to schedule the mammogram. And then the cervical cancer screening had a ability to speak with member services if they needed help in finding a provider near them in order to get those services done. We also have offered a $50 member incentive upon the completion of those screenings. For the adult measures, just a couple I wanted to mention. The adult access to preventive services, we did a IVR campaign early in November just to try to reach out to members who are either unattributed to a PCP or maybe just haven't had a visit in a considerable amount of time, and to try to help them connect either with our member services or help them find a PCP and become established. For eye exams for members with diabetes, we've also offered a member incentive. We have contracted with a vendor who kind of runs a diabetic program through an application, and we try to outreach members and get them connected with this application, which is wonderful. It provides all kinds of information on diet and exercise, and they can connect their devices, their CGMs to this, and has all kinds of tips, and providers can access the application and be able to have some communications through that as well. So those communications were given to providers within our network, as well as sent out to our members with diabetes. And then we are also working on value-based reimbursement models. It's under continued development. We do have our first one in place and more to come in the coming year as well. For UMIC follow-up measures, some of the barriers that we have for follow-up measures, especially related to emergency department visits, would be just notification that a member was in the emergency department. In most cases, health plans are notified when you receive a claim, unless you have your own hospital system to where you have internal capabilities of receiving alerts. That might be a little bit different, but we do receive what are called admit, discharge, and transfer, or ADT alerts from the CHI with UHIN. And some of the information that comes through that can be a little hit or miss. We do the best that we can, but what we do is we have some coordinators who actively monitor those alerts and then are able to notify care management if the criteria is met for somebody needing a follow-up pertaining to one of those above measures. And then what will happen is the care manager will attempt to contact the member to conduct a behavioral health questionnaire and help connect them for a follow-up appointment with a mental health specialist. We also conduct quarterly meetings with community-based providers to connect on any known issues and just make sure that appointment times are being able to be scheduled in the appropriate time frames. For members who are hospitalized due to a mental illness, our utilization management team notifies care management of that admission, at which point they would contact the hospital social worker or care manager and then collaborate on a plan for a safe discharge and ensure that they have an appointment scheduled for follow-up within that 7 days. As far as the CAPS measures go, I know, as Jennifer had mentioned, it is important to take into consideration the response rates when we do look at the results of the CAPS measures. So I did just kind of put what our response rates are there. I believe the majority of HCU's rates did improve from the prior year. It does look like how well doctors communicate is one of the ones that has decreased across the board. So that's something that we definitely will take under consideration in our monthly meetings with provider offices and just kind of increase the education around clear methods of communication and so that we can try to build a better trust for our members within the healthcare community and feel like that communication is being completed. Thank you.
Okay, thank you, Rachel. Okay, now let's go to the committee for questions. I think Stephanie and Emily had questions. So Stephanie, let's start with you, please.
Yeah, thanks, Michael. And I guess I just want to start off by saying that, like, I mean, there's a lot to unpack there. That was a lot of information. I appreciate the thoroughness. I do want to just say, like, you know, we are going to not have enough time, I think, for the amount of discussion that I do think that this warrants. I mean, we are privatizing a part of the social safety net and giving lots of money into these private entities. And I do think that it requires a more thorough and comprehensive conversation than we're going to have time for. And I just want to put on the record, we probably maybe should rethink canceling MAC meetings whenever there's so much going on. So I kind of wish we wouldn't have canceled last month. However, with that being said, I guess my first question is just like, you know, as I hear all of those, it was hard to see which plans are accounting for areas where their quality metrics have gone down. And so it was kind of hard to keep up with, like, okay, this one, like, it was kind of hard to connect, you know, all of these strategies with like what's actually working. And then also just wanted to, like, you know, put out there that, you know, I mean, some of the strategies I appreciate and some, I mean, I don't know if you're talking to consumers. I realize maybe that is not something that you all have set up yet. But like some of those strategies, it just leads me to believe that there's a real gap between what is understood to be the reason that Medicaid beneficiaries of different population groups are delaying certain kinds of healthcare and like the plans. And I think, again, like when we made a decision to go into this model, it was because there was all of this there was this argument, right, that like the plans could do better than the government and all of these other reasons, and particularly with case management and all of these reasons. And I'm just like if like getting things in the mail. I mean, you know, respectfully, I don't know how many of you also talk to other parts of your marketing departments, because I know that there are members who are getting more things in the mail from their health plan telling them that they should also have their Medicare be a part of like Medicare Advantage. And so they're using their access to them through Medicaid to then promote their Medicare Advantage plans. This is something that the double enrolled people are getting. I mean, so anyways, I mean, there is some just junk marketing sent out there. So I think that, you know, I appreciate that that was brought up, that that's something you all try to think about, maybe make sure that that's something the whole company thinks about. But then also, like, you know, I guess I just like, I haven't heard enough from Medicaid beneficiaries myself. You know, when I think about how many Medicaid beneficiaries I talk to in my own experiences, I don't hear enough from Medicaid beneficiaries that what they need is like very few healthcare services do I hear that a postcard made a difference. I do think that there are a few where that is true, but I think that there are, especially when we think about immunizations, vaccinations, and just like, you know, certain parts of healthcare where there's less trust. Medicaid beneficiaries, you know, by many metrics, have higher levels of medical mistrust. And this is something that is so important for everybody in the healthcare industry to like actually be working on how to improve the trust of, you know, Medicaid beneficiaries. And I think that like there are ways in which I question whether or not you all are hearing enough from consumers and Medicaid beneficiaries themselves. And you know, as far as I could hear, I didn't hear that referenced at all. I apologize if I missed somebody saying that they did have a part of their plan informed by Medicaid beneficiaries. But like some of those strategies, I hope they work. But everything that I know about Medicaid beneficiaries doesn't lead me to believe they are. And it just feels like we're just back here every year kind of having the same conversation. And anyways, particularly around the ones where it's been, you know, discussed year after year, I guess I just like want to know what is actually going to make a difference. And like, and again, if you all stated that, I apologize for missing that, but it's just not something that I picked up on. And so I also just wanted to say that maybe we should be more specific with what we ask the plans to present on, you know, in the future, because maybe we could help figure out what pieces would be most useful to like the kind of template of like, here's how you can present so that we can get the information we need. But I appreciate the thoroughness and the time you all put into that. If any of you referenced like which things are actually making a difference, and how it's being informed by consumers. And I hope that if you are talking to consumers, you are paying consumers for their time, just as you all are paid for your time. But anyways, I mean, this is just, some of these are just, it just feels like a little bit redundant. After several years now, every December, it's just feeling like I'm not sure what, I don't know. I do feel a little bit frustrated. So not personal, but it's just, I don't know. It's just some of those strategies just really, like diabetes, for example, like an app that tells someone about their food. I mean, the social determinants of health are the real cause of Medicaid beneficiaries having a higher proportion of diabetes, right? I mean, like there are other things. I think sometimes if we focus too much on like, trying to police behavior, it's like misunderstanding the entire conditions of their life. And anyway, that makes me just feel like, what are we doing? Like what are we doing? So anyway, I just appreciate you all, but I also feel like we could really improve this whole process a lot.
Okay, thank you, Stephanie. Emma, did you want to respond to that, or did you have a separate question?
No, I was just going to mention, and thanks, Stephanie, I do appreciate that. And I was just going to mention the fact that one of the things all the plans have been engaged in are these consumer engagement panels, which have been absolutely fantastic, where we have sat down with consumers, and it has really been good. I mean, we're asking them these kinds of questions. What are the barriers to you getting care? What are the barriers to you getting and maintaining your Medicaid? And I think it has been enlightening, and I think that's been one of the things that has really been a good step in the right direction. And this is a really complicated process, so I don't disagree. I think, because I have seen this now from both sides, so I do think it would be good at some point to just really sit down and just talk through some of the details and get some more feedback on what does work. And it has been particularly difficult during the PHE. I know we all blame that, but because it has been such an unstable situation, especially with the unwinding. But that's going to be settling down at some point, and I think we'd really be interested in getting more feedback.
Okay, thank you, Emma. Okay. All right, any other comments or questions? I think, again, it would be helpful if we could get all of the presentations from the plans that presented with the presentation. Just as Stephanie mentioned, that was a lot of information. And it'd be helpful maybe for us to have a chance to review that. And then if we have some follow-up questions or comments, feedback, then maybe we could have a follow-up discussion in a subsequent meeting. And Stephanie, to your point about canceling the meeting, this data was not available in time for our November meeting, nor was the governor's budget proposal, which were the primary components of our agenda today. So we don't cancel the meetings unless we don't have enough to really fill at least an hour's worth of people's time. So I know we've had that conversation privately, but appreciate that. At the point you bring it up for the whole meeting so that maybe other people have the same visibility there. Okay, Sharon had mentioned we do have a quorum now, and so we can go ahead and approve the meeting minutes for October. I'll ask again if anybody had any proposed recommended changes that we could consider those, and if not, I'll entertain a motion to approve the minutes.
I'll make a motion to approve the October minutes.
Okay, thank you, Rachel. Do you have a second?
I will second that.
Okay, Colleen, thank you. And then we will vote by silence. If anybody's opposed, let us know. If not, we'll accept your silence as a positive vote to support the motion. Okay, Jennifer, you've got a raised hand. Do you have a question?
I just had some trouble. Can you go back to the part that shows who was attending, just so I can make sure? I just couldn't see that part. Thank you. Okay, I'm great. Thanks.
Okay. All right, thank you. Then we'll consider the meeting minutes approved and move on to the next item on our agenda. Since we are running a little bit behind time, I'm going to reorder our agenda. We're going to hold on the Medicaid eligibility and enrollment update since that's been a staple of our agendas for the last several months. We'll go through that later in the meeting. But let's move to the director's report. I think the governor's budget proposal had been put first on the agenda because we want to make sure we get to that. So if we can talk through that, and then the other director's report changes. I know Brian's been asked to sit in for Jen Strohecker, who's not in our meeting today. So Brian, let's go ahead with your presentation. And if Eric's going to help on the governor's budget proposal, the combination of the two of you.
Thank you, Michael. Presenting my screen, and I'll start with the governor's budget. It was a few key items that we were very happy to see in the governor's budget. What you see on screen here are general fund figures, and what you do not see here is expansion fund figures and federal fund figures. I'll say that at the outset. The first two go hand in hand, expanding coverage of homeless support services and coverage for justice-involved individuals. We've spoken a little bit about our desires with the justice-involved individuals, building off of legislation from, I believe it was the 2021 general session, which gave us direction to apply for a waiver for individuals 30 days pre-release and give them a full Medicaid benefit. As we've seen other states go through negotiation process and make parameters about what's approvable, it has made some changes to our proposal. And so this item in the governor's budget would change our proposal to a 90-day pre-release option, giving a defined benefit specifically about physical health, behavioral health, and substance use disorders, similar to what California had in their waiver request. It would include intensive case management and then supports on relief. Some of those supports are housing, including up to 6 months of rental assistance. And this is where it kind of is similar to the first item, which is to provide similar housing supports, including rental assistance, to the non-justice involved population. As many may know, currently we have housing related services and supports waiver specifically for our targeted adult Medicaid population, our TAM population. So this would extend that HRSS program to other expansion adults, as well as building in the rental assistance, which we do not pay today, but CMS is creating frameworks that states can build that under what they call a health-related social needs program. So I'll pause right here. Any questions so far?
So I have a question, but let's go to the committee first. Hey, Jennifer, go ahead.
Go ahead, Michael. You can go first.
Well, mine's just a broader question. As I looked at the governor's budget proposal, I saw that some of the program funding doesn't necessarily come from general fund on some of these initiatives, and it comes from a restricted fund source. So if you could just point out the instances where one of these programs is maybe funded by possibly the Medicaid expansion restricted fund or the Medicaid restricted fund, one of those, just to kind of raise some visibility about the source of funds if it's not a general fund proposed request. I think that would be helpful. Okay, Jennifer, go ahead.
Yes. Thank you, Brian, for this information. I'll keep my question brief because I believe Andrew and Stephanie also have questions. I like to see I'm happy to see this going toward the expanded coverage for justice involved. In the past, I know they've been given very limited resources, but seeing that there are improvements, that really helps to reduce the recidivism rates, especially if they're getting the healthcare, the mental health care, and the meds that they need to stabilize themselves. I could go on and on about that, but I won't, because Andrew and Stephanie have great things to add to. So thank you again, Brian.
Okay, thanks, Jennifer. And then, so I don't know, Stephanie, if you dropped off, you were first in the
Yeah.
queue. Okay.
Oh, yeah, sorry.
Yep, go ahead. And then Andrew, you can go ahead right after Stephanie.
Mine is probably a dumb question. I just so that those numbers seem really small. So, am I missing something? I don't understand the math. So I guess I'm just like, why are the numbers so small?
Yeah, well, it's certainly not a dumb question, and you're exactly right. This is actually a very big item. So the 12,900 kind of belies the impact that we expect with this, because it is only general fund. There's a sizable amount that is expansion fund and federal funds not shown here. And so expansion fund would be matched 10-1. Or 9-1, but yeah, a 90% match on that. So these are much larger than what is shown here.
Okay.
And I do, touching on Michael's request, I don't have those exact figures. Just knowing that they are drawing from expansion fund, but not exact.
For example, just so the whole group understands, on that top one, to Stephanie's point, expanded coverage of homeless support services, you've got the figure of $12,900 ongoing, which the governor's budget sheets show as ongoing general fund, but it also shows $110,900,000 of federal funds associated with the request, and $12,581,000 in restricted funds associated with the request. So in total, it looks to me that there's about $123.5 million associated with that initiative, but the perspective being $12,900. That's just the general fund comment. So I think that raises a little bit of additional perspective maybe to those looking at the 12,000 figure and thinking, okay, how's that going to do anything other than pay for one person's rent for a few months? So then that's what I was getting to. But if you don't have the details, that's fine.
That is helpful. Thank you. I guess, so with that expanded coverage of homeless support services, how much is it mirroring Cal-AIM? Is it like a what, like, is it a more scaled down version of Cal-AIM, or is it like identical to Cal-AIM?
So Cal-AIM being the California program, right?
Yeah,
Stephanie,
sorry.
just so we're all on the same program. Okay.
Yeah, it's a good question, Stephanie. And I believe some other, we have done comparisons. I don't have those in front of me in order to give kind of a comparison versus contrasting components. It was largely built off of California. I don't want to say that it's identical because I don't have that knowledge, but it was largely used as a blueprint.
Okay, cool. Does the budget specify whether that includes the technical assistance and like capacity building for the service providers? Because whenever we brought the California person out, I had in that presentation, not that I expect anyone to remember what I said, but I asked about that point because when I talk to people there, that part is really important because of how much capacity building and technical assistance and administrative capacity service providers, especially the smaller ones, like need to be able to like participate in this project. And so I guess I just wanted to see if that is going to be included in that budget item.
I mean, there is a personnel component, and I do anticipate that being part of the personnel. I think an important point with this as well is that because it is functioning through the 1115 waiver process, there will be a public comment period as well. This would be a forum where we bring that. So certainly we appreciate those comments. Assuming next step being the legislative process as well, and there's a comment period for that, but just recognizing after the legislative process, that would be a forum. So yeah, I welcome those comments, Stephanie. Thank you.
All right, Andrew, let's go on to your question, please.
Steph, you weren't the only one. You weren't the only one to have that question. I had it too. So thank you very much for asking it. And Brian, I was curious. I think Nate answered it in another meeting I was in the other day. But is the eligibility for expansion HRSS the same as the TAM eligibility, or who are you exactly thinking would be eligible in the expansion population for HRSS services?
Thank you for your question, Andrew. So eligibility, are you referring to, for example, in the HRSS program today, it requires a set of risk factors and needs in order to be eligible. So initially, that is what we're envisioning. Yes, the same type of risk factors and needs, but I'll probably say much of the same with Stephanie's comment. This also would go through 1115 waiver process, and we would look for input along the way at how that looks. If you have recommendations, we would be open to those.
You know, I always have recommendations, right? But that's what I was wondering about. Is it so? It sounds like it's still being discussed.
Yeah, I mean, yes, with the starting point that it would be using the TAM framework, but discussions may happen. Yeah.
Great. Thank you very much.
Great. Thank you. Jennifer? Sorry, I actually didn't know if Michael, you wanted to moderate calling on people or not, but yeah, happy to take other questions.
I'll make it very quick. I just wanted to thank Stephanie and Andrew for piping up. I just want to close with, again, thank you for focusing on this population. I will look forward to seeing maybe some follow-up in the future, because I've seen the before and after with those who are justice involved, and I just want to say it makes a difference. People can go on to be wonderful spouses and parents and make a great difference in the world because of when people invest in these programs. So thank you.
Great. Thanks, Jennifer. Okay, I don't see any other questions. One question I had asked for, let's see, Stephanie, go ahead.
I'm so sorry, Michael. You can go first. If we were done with the budget, I did have one more question, but you can go first if you'd like.
Well, one of the things I just wanted to bring into focus is tying our MCAC processes together for the whole group. Everybody remembers we had the public hearing back in May, and then we had the voting in the June meeting in terms of what the MCAC's recommendations were. And in our MCAC executive committee, I had asked Jen if she would make sure to highlight what appeared in the governor's budget proposal and how that compared to any of the recommendations that the MCAC had made and where they were in the prioritization. process. So it seems to me, Brian, like you've been stuck holding a bag with a lot of to-dos, but not a lot of the information passed along to help you prepare for that. So if you don't have that, I totally understand, and we can just have that highlighted in the January meeting.
I'm happy to highlight that later. One thing we have talked about, specifically that last item, HCBS waiver rate increase. My understanding is that was the second priority defined by MAC.
Okay.
But yeah, we can come back with the other information. Yeah.
Okay. Yeah, I just think that would be helpful for everyone who participates in the MAC, especially for those who take time to make the presentations, and for the committee members who review those and then vote to prioritize them, just to see that, something we did 6 months ago, here's how it kind of fulfills its work in the governor's budget proposal, so we don't lose track of that in our processes that take many months. So great. Okay, Stephanie, let's go back to you. Thank you.
Thanks. And I love that comment you just made, Michael. So I agree with that. I was curious, I don't know if DWS is on, but was there anything in the governor's budget for DWS to improve? Just thinking about how much time we've spent this year discussing the unwinding and, the way in which we are not doing an adequate job. And so I'm just wondering, was there anything in the governor's budget? I remember in the summer we were talking about overtime. So staffing, that would be something that would be good to ask for more money so you could hire more staff. Just wondering about things like that. I didn't have a chance to review the whole governor's budget ahead of time, so I apologize, but I just thought I'd ask and see if anyone is able to comment on anything related to eligibility and enrollment improvements.
Hi, Stephanie. This is Melissa. There is nothing in the governor's budget tied to staffing for DWS. That's something that we come up with based upon future things like unwinding. And so we had that previously, but nothing in the upcoming budget.
Thank you, Melissa. So just so that I understand, you all are not asking for any more funding for eligibility and enrollment?
Not currently, no.
Okay. I guess for whoever would like to know, I find that disappointing, but that is, I recognize that's, I don't know if anyone from the governor's office is here, but with how many children and just people have lost health coverage, I would have hoped that there would have been something that would have showed up in the governor's budget related to that as an important priority. But I also understand it's not your fault, Melissa. Just wanted to share my disappointment, but thank you.
Okay, thank you, Stephanie. Good feedback and tying into some of our previous meetings as we had talked about that. Andrew, do you want to go ahead with your question, please?
Yeah, and Brian, I will happily sit back if you're planning on talking about the other two items already, but I am curious because the HCBS waiver rate increase is a broad and potentially all-encompassing term. So I'm just wondering what that refers to specifically, and then also if you could give a brief overview of the psychotropic oversight and what that entails.
Yeah, I'm happy to. Thanks, Andrew. Yeah, apologies. I didn't say when I was pausing that I did plan to address the others, but thank you for the question. So the HCBS waiver rate increase would appropriate funds for our employment-related personal assistance service program, or EPAS, and aging waiver rates for most of the funds would be for attendant care, as well as new choices waiver. It would also help some rates beyond the waivers, which specifically are personal care, state plan rates, and home health. So it is a pretty broad investment, and if passed, it would do a lot of good there. But specifically, EPAS, aging, new choices, and some state plan rates is where that would be focused.
If you would like somebody to testify in support of all of those, just let me know. So, thank you very much.
Yeah, a very good point, Andrew. And certainly when this does go through the social services process, your voice is very beneficial. So we welcome that. Thank you. The psychotropic oversight, this is a combination of a couple items. The foster Medicaid parity, that would allow us to reimburse providers serving foster children Medicaid, particularly behavioral health services, reimburse them the same that we do for our other non-foster care individuals. We have had disparity there. This would appropriate funds so that we can close that. It would also make some changes to the Utah Psychotropic Oversight pilot program, which would no longer become a pilot and become a ongoing program oversight over some psychotropics that are delivered to foster care individuals. So those two are combined in one item there. The middle item, I don't think I touched on either, but that would provide some specific provider rate increases to primary care providers. This is a prerequisite that CMS requires for adopting health-related social needs waivers. They actually require that states be at least 80% of Medicare in their rates for obstetrics, behavioral health, and primary care. In our review, we found that we needed an increase for primary care to achieve that, specifically raising primary care rates by a little bit more than 2%, which would allow us to become eligible for that health-related social need waiver, which supports those housing items. So at this point, I think I have touched on all of those governor's budget items, but if welcome any other questions if there are any.
I just want to, Ryan, this is Andrew again. I just wanted to say thank you for the detail in that explanation. It will help us be able to talk at least somewhat intelligently about them during the session. So appreciate it.
Thank you, Andrew.
Nate Checketts, let's give you the floor.
Thank you. I just wanted to build on what Brian was saying and also address some of the requests that Andrew submitted, which were the #1 priority for the MAC. There is additional funding in the governor's budget for services to bring people in off of the wait list into the DSPD program, including some funds that are targeted or some direction to look at the individuals that have been on the wait list for a significant amount of time. So we're looking at potentially those that have been on the wait list more than 20 to 25 years are in there. There was also some action that the department took earlier this year that addressed another item that was in Andrew's list that he discussed with the committee related to nursing services for individuals that come out of the intermediate care facilities. So that was the #1 priority item on the MAC, was this list that loosely may be called an omnibus request from Andrew that had a variety of items related to mental health and other services, but just highlighting a few of those that are also in the governor's budget.
Okay, thank you. Yeah, I just pulled it up from our June meeting minutes. Mental health and developmental disability systems and Medicaid was the #1 ranked item, which you just spoke to. And then the HCBS waiver rate increase was #2, which has been addressed right here as well. So that's helpful. Thank you. Okay, Brian, do you have any more on the governor's budget? Or we're moving to policy updates?
Nothing else on the governor's budget, but I
Okay,
can
great.
move to the policy updates.
Let's just
Yeah,
keep going.
so
Great, thanks.
thank you. Recognizing times starting to pass, so I'll just touch on some really positive things that are going to be rolled out January 1st. First being our state CHIP program. This will allow us to expand coverage to children who are otherwise eligible except for citizenship, and we'll be able to roll it out to 2,000 children beginning January 1st. Our 12-month postpartum coverage, this allows us to extend from the current policy of 60 days after pregnancy ends to 12 months. Guaranteed coverage through 12 months after the pregnancy ends. 12-month continuous enrollment for children. I think this committee is aware of the long history with this item, and it will finally be a reality January 1st of 2024, as well as non-traditional to traditional benefit changes. Those individuals that up to December 31st have been receiving a non-traditional benefit plan will begin receiving the traditional benefit plan. It will extend services like non-emergency medical transportation, some increased access to physical therapy, occupational therapy, and a few other changes. We will also be opening coverage to recreational therapy. Recreational therapy is an evidence-based service providing support in a behavioral health setting. We are excited to see that rolled out. Telephonic medication therapy management, MTM for short, we already support this in a face-to-face environment. What this would allow us to do is the audio-only equivalent of the service by telephone. And that will also be live on January 1st. And then finally, an associate physician, recognizing that as a provider type, these are physicians that have completed medical school, just not residency. It is a fairly rare designation. I believe there are fewer than 5 in the state of Utah, but there is a specific part of the Practice Act that does identify services that they can deliver primary care specifically, and this would allow us to enroll them as Medicaid providers. So we are excited about those changes, and I can be available for questions.
Okay, looks like Rachel has one. Go ahead, Rachel.
Thanks for all this, Brian. Mine's really quick and you might not be able to answer it. Do you have any updates on the medical respite waiver that's been in CMS land for a couple years now?
Yeah, thank you for the question. We have talked about it frequently, as recently as earlier this week with CMS, and going through a number of revisions. Budget neutrality has been an obstacle, which is this calculation that CMS requires us to do. We are working through the approval process, but it has taken longer than any of us would have wished, but we're still working through it.
Yeah, thank you. That wasn't accusatory. I know that there's a lot of negotiations, but thank you so much. I was just figured I'd ask. I hadn't heard about it for a while.
Thank you for the question. Yeah.
Great. Okay. All right, let's continue on.
Yeah, so that concludes my presentation.
Okay, so we had audit updates and UHPP updates and behavioral health delivery work group updates. And then Jen had also mentioned in our executive committee that she was going to follow up from an October item that was discussed in the MAC about some research that the department had requested Lighthouse Research do. So if you could just touch on those.
Yes. Will do. So I'll start with the most recent thing you mentioned, Michael. The Lighthouse Research item is unwinding survey or disenrollment survey, I think is the proper term. We are working towards sharing that very soon. I don't have it right this moment, but we will be sharing it very soon with this committee. I'll go bottom to top. The Behavioral Health Delivery Work Group, we met last week, continue to meet quarterly. We're working towards final recommendations. We have sometimes referred to this as the HB 413 committee, that enacting legislation which required 5 recommendations to be delivered to the department to make a determination, or they make a determination based on some of those recommendations and other factors. We're still getting those final recommendations from committee members on behavioral health delivery, both for TAM members and the broader population. But we've had positive discussions there. UHPP, we've had very positive rollout of the contract, including extending their hours of operation, support for community health workers, provider training. I think we have some UHPP representatives here, and if any would like to add their thoughts, that would be welcome.
Hi, this is Daryl. I'm the Take Care Utah director. Thank you for that. It's been a while since I've been on one of these meetings, and I have not been on the meeting as the director, but our staff has been totally slammed. As I'm sure all of you know, we've done 40% more applications this year than we did last year so far, with basically the same staff. And with, as Brian was mentioning, with the support of the Medicaid office, we were able to extend our hours. From 8 to 6 on the weekdays, and we've got about, we have Saturday hours, which get filled up instantly. As Brian mentioned, we're doing some training for community health workers and medical office front staff so that they can at least try to direct people in a good direction. And beginning next year, we're going to be kind of hitting the ground, going to the Department of Motor Vehicles, emissions inspection stations, laundromats, among others, with tablets in hand to help people understand when their review date is, and get connected with someone that can help them with that. So it's, we're a small group doing as much as we can. Hopefully, we can reduce by a couple some of the agonizing stories that we've been hearing. Thank you.
Thank you, Daryl. We certainly appreciate the work. Michael, would you like me to proceed? Or pause for questions?
Well, Stephanie, do you have a specific question here? Or
Sorry, it's fast.
Yeah,
it's really fast. I just wanted to say, make sure I heard that right. Did you just say y'all are going to be starting some of that outreach next year, like in January?
Oh, Daryl, sorry, you're muted.
My bad. Sorry about that. So new outreach that I was mentioning around DMV and laundromats, that's going to start in January. Yeah.
Okay. Are y'all going to keep us posted on how that goes? Have you all haven't been doing that throughout the unwinding since April?
We have been attending about 40 events a month, but none that were directed towards these locations. And absolutely, we'll totally be letting you know how it goes. I hope it works.
Okay, thank you.
And
Go ahead, Brian.
but sorry, I'll just round out the presentation. That as far as audit updates, we're continuing to work. We have 2 audits. The HHS OIG is performing an unwinding audit on us. We're going back and forth on questions, providing them answers timely, and then the Office of Civil Rights, we've completed the initial data poll and are waiting for response back from them. The legislative updates, I think, is largely the governor's budget that will be taken to the Social Services Appropriation Subcommittee, and I believe that's
Yeah, I think
that
we
will
were
round out the
just
presentation.
interested on the legislative updates in addition to the governor's budget. If you were aware of any things legislators have been talking to you about new policy initiatives that you were in a position to share with the MAC to raise any visibility.
I personally am not. I don't know, Nate, if you know anything shareable.
Yeah, it was just as that question was asked, I was doing the same thought process. I'd have to think through how many of those are more public, and how many we field questions on a regular basis throughout the year from legislators on their interests. And yeah, I'd have to go back and think how many of those are they're public. They've announced publicly what they're working on.
Okay.
We've been involved. I think we have to talk publicly about this, and we've been involved with the Behavioral Health Master Plan and the Behavioral Health Commission, and have worked with Senator Vickers on that bill, and we've had public discussions about that one. I think I'd have to think about that one, about if there's any others that we can talk about.
Okay, thank you.
Michael, it's Andrew. Can I ask Nate a quick question?
Well, sure. Whether he's willing to answer it or not will be left up to him. But you've got 1 minute, Andrew. Give it your best shot.
Sure. Thanks, Nate. I was just wondering if for those who may not have heard about it yet, but I was wondering if you could share as much as you're able to about what care court is, or sorry, home court.
Home court
is going to be, and the thinking around that as far as it's gotten to this point.
Yeah, sure. I'd be happy to talk about that. So home court is an item that's in the governor's budget. It has 2 funding components. It has, and I don't remember the numbers, so it has hundreds of thousands of dollars that go to the courts to fund that they would have a judge and supporting staff to be able to involve in this. And then there's $10 million one-time funds given to Health and Human Services to provide the support services related to this. What the home court is intended to do, civil commitment is a level that individuals reach if there's certain issues going on when they are a risk to themselves and others. Home court is intended to be sort of a step below that. Before individuals reach that level, they could engage with home court, engage with the judge, and then Health and Human Service would provide these services with them. It is a pilot. It is intended just to function in the 3rd District Court. And so that's primarily that would operate in Salt Lake County.
Okay, Stephanie, question?
I'm sorry, everyone. I just wanted to ask Brian, when you say the audit, like, we never got more clarity on what the audit was asking for. Are y'all just going to tell us that at the end? Or is that something that, like, we can know about? Like you said that you're giving the data, but like, what exactly was it? Like, what was the goal of the audit? Are you allowed to share that?
Yeah, Stephanie, thanks for the question. Are you asking about both audits or one in particular?
Both, either, whatever you want to give.
Well, I mean, for perspective, the HHS OIG audit, I do believe it was around 41 states that were under this audit, largely around processes. I don't have all the questions in front of me, but processes, proper notice, items like that, some data to provide, and then going through, they will be doing sampling of cases and reviewing. The OCR was largely looking at disparities, any disparities that may exist. And so the questions were largely around data segmented by race, ethnicity, gender. That was the focus.
Thank you. Thank you for all the work. Y'all are very busy, and I really, really am very grateful. So thank you.
Thank you, Stephanie.
Okay, well, we are at 4 o'clock. There's always a lot to discuss when we start getting into some of these things. So thank you for the presentations and the questions and the participation from the members of the MAC and the public today. We'll go ahead and adjourn our meeting and see everybody back here in January.
Thanks, everyone.
Thank you.
Thanks, everyone. Merry Christmas. Bye.
Yes, have a great holiday. Thank you.